Chapter 4. Pharmacological Interventions. Buprenorphine is another cornerstone medication in opioid substitution therapy, offering a distinct pharmacological profile compared to methadone. As a partial opioid agonist, buprenorphine activates the opioid receptors in the brain, but to a much lesser extent than full agonists like methadone or heroin. This partial agonist activity provides a ceiling effect that reduces the risk of overdose, making it generally safer, especially in situations involving accidental or deliberate overuse. One of the most beneficial aspects of buprenorphine is its ability to block the euphoric effects of additional opioid use. At adequate doses, it effectively occupies the brain's opioid receptors, thereby preventing illicit opioids from producing their desired effects. This can reduce the incentive to continue using heroin or other opioids, supporting recovery and stabilization. Buprenorphine is available in various formulations, including sublingual tablets or films with or without naloxone. When combined with naloxone, an opioid antagonist, the product is designed to deter misuse. If the combination product is injected, the naloxone becomes active and can precipitate withdrawal symptoms. When taken as directed, the naloxone remains inactive. This approach reduces the likelihood of intravenous misuse while preserving the therapeutic benefits of buprenorphine. A key clinical challenge with buprenorphine is the risk of precipitated withdrawal. Because of its high affinity for opioid receptors, buprenorphine can displace other opioids from the receptors, leading to sudden and severe withdrawal symptoms if given too soon after other opioids like heroin or methadone. Therefore, proper timing is essential when initiating buprenorphine, particularly for patients transitioning from methadone. A minimum of 24 to 36 hours is typically recommended after the last methadone dose, depending on the patient's clinical presentation and methadone dosage. In terms of administration, new long-acting injectable formulations of buprenorphine are also available and increasingly used in practice. These depot injections offer the benefit of sustained release over a week or even a month, enhancing treatment adherence and convenience. They may be particularly helpful for individuals who struggle with daily medication adherence or who are at risk of diversion or instability. Despite its strong safety profile, caution is still required when prescribing buprenorphine in individuals who use other sedatives, such as benzodiazepines. While the overdose risk is lower than methadone, combining central nervous system depressants can still result in dangerous respiratory depression. Clinicians should thoroughly assess concurrent substance use and counsel patients on the increased risks. Buprenorphine, like methadone, should be part of a comprehensive treatment approach. Psychosocial interventions, regular monitoring, and multidisciplinary care planning remain essential. Shared decision-making is critical when determining whether buprenorphine is the appropriate medication, taking into account the individual's history, preferences, and treatment goals. In summary, buprenorphine is a highly effective and safer alternative to methadone for many patients. Its unique properties, including the ceiling effect, reduced overdose risk, and formulation versatility make it a valuable option in OST. However, successful outcomes depend on careful induction practices, awareness of polydrug use, and integration into a wider framework of support and recovery-focused care.